All right. So let's look at the analyzing strips. So first step is let's see how to calculate the heart rate. Okay. There are a few methods suggested by the textbook. So we're on page 694. One method is to count the big boxes. And also second method is to count the small boxes. And you can also count the number of heartbeats, meaning how many PQRSTs in a 6-second strip, and multiply by 10. Okay, that's the same as this one, the RR interval. It doesn't have to be the RR interval. It could also be PP, okay, or TT, whichever method you prefer. All right, let's look at this example. All right, now every ECG paper has big boxes and small boxes, yeah? Okay. So to apply the three methods, let's just do the most practical way. If the rhythm is normal, I mean regular here, what I mean by that is, say, for you to analyze the regularity or irregularity of a rhythm, let's look at how often each wave occurs. So let's say let's see how often the R occurs. So this is the R wave right here. The next R wave is here. So let's move this one from this one to this one to this. Is it about the same? Yeah. Okay. And let's look at the R. Okay, so that was the P. So let's look at any two R's. This R, that R. About the same? Okay, so what can you say about this rhythm? Is this a regular rhythm? Yeah, okay. So the methods here suggested by the textbook, which is R to R, will apply. Now let's look at a 6-second strip. So you have to mark your own 6 seconds because this sample did not have a marker. Now it'll be great if there's a marker, but depends on what the NCLEX will give you. There's a marker, 3-second marker or not. If not, make your own 3-second marker. Really simple. How many seconds is one big box? 0.2 seconds. So therefore, 1 second will have how many big boxes? So if each big box is 0.2 seconds, so how many big boxes in 1 second? 5, right? 0.2 times 5 equals 1. Okay. So 1, 2, 3, 4, 5, that's 1 second. 1, 2, 3, 4, 5, that's 2 seconds. 1, 2, 3, 4, 5, 3 seconds. So you put a 3-second marker there, right? I can't write because all right? Or you can just do it manually. Okay, just eyeball. So let's say, where did we count? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. That's 3 seconds, yeah? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Okay, let's stop right here. This is last class didn't clean the board. Oh, is there alcohol left? Give me that spray, please. Oh, yeah. Let's go again. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. That's 3 seconds right there. 1, 2, 3, 4, 5. 5. Okay. So we have a 6-second strip. So our 6 seconds is, this is 3 seconds, that's another 3 seconds, right? Okay. Right. So let's count how many heartbeats are in this 6-second strip. Can we count this one? Why not? It's not a complete heartbeat, yeah? This is a complete heartbeat, okay? So 1, 2, 3, 4, 5, 6, 7, 8. Can I count this one? Almost, yeah? However, since this is 6 seconds and this heartbeat does not count, correct? Can I move the whole strip here for this thing to start here? Yeah? So if I move that, that means, will this now fall under the 6-second strip? Okay, so it's 8 now, right? So 1, 2, 3, 4, 5, 6, 7, 8. Yeah? Is it really 80? No, because I only need one small box here. Okay, I only need one small box and this is now 8. That means I still have enough time here. I have about 9 boxes here, 9 small boxes to spare. So is this really 80 or 80 something? It's 80 something. Okay, so that's the first method. Just count heartbeats. Next heartbeat, so let's use these small boxes and big boxes method. Which one you want to do first, small or big boxes? Okay, let's do big boxes. So pick any 2 waves and we'll count the big boxes between those 2 waves. You want to do R's or P's? It's up to you. Okay, R. And which 2 R's do you want to count between? This and this? Which one? You take a pick. Which one? This one and which one? This one or that one? To there, right? Okay, so that's good choice because now you can count 1, 2, 3, right? That's 3 big boxes. And what is this? 3.5? Yeah. Yeah, so there's 3.5, yeah? So how many big boxes in 1 minute? 300. So 300 divided by 3.5. How much you got? 300 big boxes divided by 3.5. So about 86, yeah? So is it different from what we counted from the first method? About the same, yeah? So we got the same answer. All right, let's try the small boxes method. Let's try 2 different R's. Like I said, we can use this method, any of the 3 methods suggested by the textbook because this heart rhythm is regular. Okay, remember? They're occurring regularly. See, the same. So, doesn't matter which method you use, it will come out the same. So let's look at the small box method. So give me 2 R waves. This one, this one, this one. Which one? Want to try this one? Okay, this one and that one. Okay, so let's count how many small boxes are in between these. So I'll take a shortcut. That's 5, 10, 15. So I count here 16, correct? 17, 18. So about 18 small boxes? Okay, so 18, divide that into 1,500 small boxes. 1,500 divided by 18, how much you got? This may be 17.5, really, actually. It's not really, yeah, it's not really a whole, see? It's not really smack in the middle. So I would say maybe this is 17.5. So 1,500 divided by 17.5, what's your answer? Still the same. See what I mean? About the same answer. Okay. Any question about how to count the heart rate? Really simple, yeah? Okay. Now in practice, you may be using a caliper. A caliper costs about, depending if you're using plastic or metal, a plastic caliper will probably cost you, I don't know, $2, Walmart. A metal one may cost about $9. But the problem with calipers is they walk. You know what I mean, right? Right? When I say they walk. Like you put it on the table, you leave, you come back, they walk. Okay. So find one, make sure the description of the product is that they don't have legs, that they can't walk. Maybe they crawl though. They disappear like pens. If you have a good pen, good pens walk too. Yeah. All right, so after counting the heart rate, let's go now to our rhythm. So what are the 5 questions again you expect on the exam, both for mine and the NCLEX? What are the 5 possible questions? What does it look like? What are the causes, signs and symptoms, interventions or treatments, nursing education? Okay, so let's start with the normal first. These are the characteristics of a normal sinus rhythm. I won't read them for you. Please read them on your own. This is what it looks like. And because this is normal, then there's no cause, okay? There's no signs and symptoms to speak of. There's no treatment required. There's no teaching required. All right, let's go now to the abnormals. We divide the dysrhythmias into, for our purpose, since we're doing basic, we'll just do atrial and ventricular dysrhythmias. There are junctional dysrhythmias, which we won't talk about. And finally, the third category will be heart blocks. There are 3 heart blocks. So first is, let's look at the 2 evil sisters of the sinus rhythm. They are sinus bradycardia and sinus tachycardia. The only thing wrong with these 2 is the rate. All other measurements are normal, meaning that there's a P wave, PR interval is normal, QRS complex duration is normal, ST segment is normal, T wave is normal. What's the only thing wrong? The heart rate. Sinus bradycardia means the heart rate is below 60. In sinus tachycardia, the heart rate is over 100. Okay, that's the only thing wrong with these 2 rhythms. So let's answer the 5 anyway. So what does it look like? That's what sinus bradycardia look like. What are the causes? Okay, the causes are here. Now, unlike, there's only one textbook that I found a table that the author made a table for you, okay, with all those 5 answers. This one, you have to make your own table because all the information are in paragraphs, except the treatment. The treatment is on one big table. Okay. So what can cause sinus bradycardia? There you go. Okay, so athletes like me, so people like me and Anthony have lower heart rates. Okay, we normally have sinus bradycardia. Okay, so if you're toned like us, ripped abs and all everything, so we have sinus bradycardia. Are you pouting your lips at me, Tanisha? Be careful. Haven't made the test yet. Have to make changes. So here are the activities and also medications that will cause sinus bradycardia. So I can do this in a select all that apply question, right? Sure you're able to answer. Next question is signs and symptoms. Okay, this is pretty simple. What again are the signs and symptoms of lower cardiac output? Syncope, no, fainting, what? Yeah, fatigue, shortness of breath, okay. Low urine output. What else? Diaphoresis. What else? Low cardiac output. Okay. Interventions. Let's go to management. Management is pretty simple. It depends. Does the patient have symptoms? Okay. If they have symptoms, well, you have two choices. You either identify and eliminate the cause, meaning if you find out what's causing this patient's sinus bradycardia, so you look at the list. Maybe it's these medications, or maybe the patient's doing this. Okay? They're vomiting, or they're in pain. You're suctioning them, or let's say they're giving birth to a really big turd. That's causing it. Then you treat it, and then you get rid of the dysrhythmia. If you're unable to find and treat the cause, then medications will be applicable or appropriate. Okay, so that would be atropine. So the table is a few pages down, so I can't go there yet. Actually, it's mentioned here. So here's your treatment. Atropine 0.5, IV bolus, meaning that's IV push. You can repeat every 3 to 5 minutes. Maximum is 3 milligrams. So what does that say about a drug when you're able to repeat it every 3 to 5 minutes? That means the drug has a very short half-life, okay? A few minutes, couple minutes. That's it. Oh, sorry. Teaching, of course, is what? What do you teach the patient? Okay, depending on the cause, right? So if the patient is, let's say, constipated, then you teach them to, okay, take your fiber or your stool softeners, etc. All right, so you treat the cause, all right? Any questions on sinus bradycardia? Very good. Let's go to sinus tachycardia. So same 5 questions. What does it look like? There you go. What are the causes? There you go. Long list of causes. Again, including medications. Signs and symptoms? Depends again. So if the patient has symptoms, then they will be signs and symptoms of what again? Low cardiac output. Go straight to management. So how do you treat it? So same as sinus bradycardia, what do you do first? Assess the patient. Is the patient symptomatic? There are no symptoms. Do you really need to panic? No. Patient is tolerating it, meaning there's no need. Okay, so all you do is, I'm not saying there's no intervention. Okay, of course you find the cause. Okay, so try to find the underlying cause. Maybe it's fever right here. So there's fever, for instance, or the patient's blood pressure is low. Okay, maybe that's it. So the reflex sympathetic nervous system stimulation. Yeah. Okay, maybe the patient's scared. Okay, or maybe they're dehydrated. Yeah, that causes sympathetic stimulation. Yeah? Okay. If there is symptoms, then the patient will have the following options. I mean, the provider. The provider can, and I emphasize that provider. Okay, are nurses doing these? No, okay, we do not do it. This is above our pay grade, meaning your insurance, if something happens to this patient, the patient dies, you are not covered by your malpractice insurance because you are doing malpractice. Okay, nurses aren't supposed to do these. Are we clear? Only doctors. So vagal maneuvers can be carotid sinus massage, meaning they'll massage the carotid one at a time. They can do these, or let's say they can also do, they'll give the patient a straw, okay, have them blow through a straw. Or if not a straw, they'll give them a 10 ml syringe and have them blow into that 10 ml syringe, an empty syringe, okay? It simulates blowing, yeah? Another is the medication will be adenosine, right here. Adenosine is effective for sinus tachycardia as well as supraventricular tachycardia. Let me show you a brief video on how to give. That way you know what to give the provider. Because it's adenosine has a half-life of about 10 seconds. Okay, so you need to give it fast. 10-second half-life. Okay, so it's gone in 10 seconds. So do you give it over 1 to 2 minutes? No, because it's gone in 10 seconds. So it's given really rapidly. So you need to give adenosine fast, and it should be given, you should
Your
give
child
a,
needs these three key factors to get into an
20
Ivy
ml
League or
flush
top
after
25
the
university.
Okay, so you see this patient's heart rate is fast, right? Look at that, 173. You see it? Okay. So you have to administer adenosine with a three-way stopcock. I'll show it to you in a moment. Okay. So they draw up, adenosine comes in 6 milligram vial. So the first dose can be 6, or some doctors will give 12. Okay. So this is a three-way stopcock. Okay, it's just an attachment. I'll show you. We have one in the lab. So it's a three-way stopcock. That way you can close all 3 or open all 3. Okay, so this one all will be open. So this one is the dial is switched to all open. Okay. So here's your flush, and adenosine will be attached here. So this is your valve, your patient's IV. Okay, because do you have 10 seconds? Imagine if you have to attach the syringe with adenosine, push it, detach it, attach a flush, and then flush again with another one. Do you have time? Will you make it in 10 seconds? No, you'll waste time, right? By the time you give it, the drug is no longer effective. So you need a three-way stopcock. That way, you push the adenosine and then you push the flush right after it. All right. So that's the importance of this device right here, this attachment. Okay, so here's your flush, and here's the adenosine. Okay, so adenosine, flush, and the IV. Okay. All right. So watch what happens.
Okay, we've got our adenosine and our flush. Let's turn this so that all ports are
Now
open.
all ports open.
Okay, and when I go ahead and push down, I'm gonna keep pressure on the plungers so that it doesn't back up. All right, everybody ready?
Ready.
Okay, we're gonna push the adenosine
watch the
first
monitor,
immediately,
okay?
followed by the NS flush. 1, 2, 3. All right,
Okay,
adenosine.
so the whole thing took like less than 5 seconds. Yeah. Okay. So right now the heart rate is. Look at the rhythm. Okay. Want to turn this off so you can see. Okay. So watch the rhythm a few seconds after administration.
Is in.
Look at that. There's a systole, correct? The heart stopped. Okay, now that is expected. Okay, that's what's supposed to happen. This is not something abnormal. Okay, so the adenosine stops the heartbeat. Then watch what happens after a few seconds. Okay, so it zooms right back, but look at the heartbeat now. It's now normal sinus. Okay, so that's how fast it is. Sometimes it just takes 1 dose, 12 milligrams, sorry, 6 milligrams, but sometimes the patient may require a second dose, which is usually 12. But each vial is 6 milligrams, and that's how we give it. So of course, we try non-pharmacologic first. So, the patient will undergo either carotid sinus massage or the straw or the syringe, and the cold towel. If they don't work, then the doctor will resort to adenosine. Okay. Usually, since this is not technically, a code, meaning the patient is not having a heart, VFib, meaning the patient's not. So you don't necessarily call a code. You may call a rapid response, okay, for this scenario because the patient's heart is beating. So you call rapid response, they come in. Usually they don't want you opening the crash cart because when you open a crash cart just for adenosine, you're wasting the whole cart because now the cart is open. That means pharmacy has to replace that whole cart because you opened it. So they suggest just grab the adenosine from the Pyxis or the Omnicell. Okay, just go grab it from your medication room, right? Because you only need like maximum 3 vials. Okay, so 6 milligram vials, all right? So you don't get, yelled at by your supervisor for opening the cart just for adenosine. So it's available in the med room, yes. Sorry again? No, not necessarily, because you're not the one administering this. The physician usually is. But make sure you have the 3-way stopcock, okay? The doctor can't do it, meaning unless there's Flash. You know who Flash is? The Marvel hero? Yeah, Marvel the Flash can probably, doesn't need a 3-way stopcock, but we're not Flash, so we need a 3-way stopcock. So if you ever charge nurse for the day, make sure you have a 3-way stopcock somewhere, all right? Meaning, it's embarrassing, right? Meaning you have this emergency and then you just need that one lousy attachment, just that one lousy equipment, and you don't have that, which can cost the patient's life. Yeah? Yes.
Let's talk about the half-life of
Adenosine?
Yeah. Does it stick whether as soon as you get into the
Yeah, you need it into the heart, in less than 10 seconds.
so once you draw it from the small bottle, that's when you start to take effect, or once you get into
Of course not. Once it enters the patient's body.
once you enter the
Just like the tablet, the tablet has a certain half-life. Doesn't start until you swallow it. Okay. All right, another option is cardioversion. We'll talk about cardioversion a little bit later because it's not until later in the chapter. So any questions on sinus tachycardia? Very good. Let's now go to sinus dysrhythmias. Okay. Sinus dysrhythmias, or also called atrial dysrhythmias. Sorry, atrial dysrhythmias. I meant atrial dysrhythmias. These are, of course, any dysrhythmias which are caused by things above the ventricles. Okay. So you have 4 atrial dysrhythmias. They are PACs, premature atrial contractions. You have atrial fibrillation. You have atrial flutter. And you also have, I forgot the 4th one. All right, so let's start with PAC first. PACs are basically harmless. What do PACs look like? Here's a PAC. So you can identify a PAC because the rhythm is, look at this patient's underlying rhythm. This is the normal rhythm. This one, that one, that one. Okay, so those are the normal beats, meaning this patient's normal interval is this one. Okay, that's the patient's normal interval. See that? This one is abnormal. Okay, if you're not clear. So this is the patient's normal interval. Okay, that one, that, and this one and this one. How about this one and this one? Clearly, it occurred prematurely, and it's easy to spot because you see a pause after it. Okay, all PACs, PBC always has a pause following it. Meaning these are normal beats. These are normal beats. This one is a premature beat. The premature beat always has an abnormal looking P wave, right? So this P wave will look nothing like the other P wave. See, this is a P wave, P wave, P wave. We don't see this, but this one, this one, this one are normal, not this one. This one doesn't look like a normal P wave at all, right? So that's another difference. So what causes a you have the textbook right open, eh? All right. So that's what it looks like. I'll skip through the table for now. What causes PACs actually was mentioned here. So PACs are caused the same as PBCs. So smoking, coffee, who are coffee drinkers here? Like regular coffee drinkers? Like venti or grande? Okay, so if you're that type, constantly coffee, everywhere you go, coffee, you go to the lab, coffee, I have to call you out, take that outside. Okay, so without you knowing it, I'm sure you're having PACs or PBCs. Okay, that's what causes it. Coffee, anxiety. So you have anxiety, you have exams, so all of you have PACs or PBCs. Okay, it doesn't mean you have a heart disease, all right? So it can occur with people like you, people here. Okay, of course, once you have these risk factors, do you really want to test your heart? You really want to test how far it will go? No, of course, you try to cut down on these. Okay, so don't get pregnant every month. Okay, it's every couple years, right? Like my mom was pregnant 15 times. Okay, she had 13 with my father, and yeah, she said she got one miscarriage, and then I have a half brother from her first husband. Okay, so she got pregnant 15 times, right? So I'm sure she had tons of PACs, yeah? We're only 3 months apart. Yeah, Sheila was like a chicken. Pregnant every 3 months. Of course. Now, so those are the causes. Let's look at treatment. Treatment, there's really nothing as far as treatment. I mean, here, if they're infrequent, all you do is cut down on coffee, cut down on smoking, okay? It's better relaxation technique. There's really no treatment for PACs except identify and eliminate the cause, all right? Any questions? Okay, before I go to AFib, let's look at the table for your medications. So this is your only drug chart, table 22-1. So there are 1, 2, 3, 4, 5 columns here. And all the information you need is here already, meaning what is it for, meaning which dysrhythmia is it for. And most importantly is the 5th column, which is the nursing interventions. Of course, I will also test the side effects, but side effects is pretty straightforward. Now, nursing interventions, you have to know what to do when you are giving the medication. And if you look at the side effects, they have one thing in common. It's all dysrhythmias. What did I say earlier at the start? An antidysrhythmic can cause another dysrhythmia. Okay, so that's a term we call pro-dysrhythmia, meaning an antidysrhythmic agent will cause or favor another dysrhythmia. That's the concept of pro-dysrhythmia. Pro meaning for, right, or favors another dysrhythmia. Okay. So which drugs? Well, all of them. So for here, you have procainamide, lidocaine, lecanemide, and you should know beta blockers. Okay, we have acebutolol, atenolol, bisoprolol, okay, timolol, propranolol. You have amiodarone. These two are calcium channel blockers, but they are the only two used for dysrhythmias. The other calcium channel blockers, which end in dipene, nicardipine, nifedipine, normodine, okay, all that ends in dipene are DHP calcium channel blockers. They're not used for dysrhythmias. Only these two are. Only verapamil and diltiazem. All right? They come in pills and also IV. All right, let's move on. AFib. This is the most common dysrhythmia in people age 65 and over. Our chances of getting AFib increases as we age. Okay, so once we hit 65 and older, we may have AFib already. There's treatment for AFib. We'll discuss it shortly. AFib, you don't die from AFib, okay? You die from the complications of it. AFib can be just AFib, but if you have AFib with rapid ventricular response, meaning the heart rate reaches 200, 300, yes, of course you die from zero cardiac output. Another cause of death will be blood clots. Okay? So AFib and aflutter are similar. I should say identical because they look different, but they have the same consequences. Okay? So atrial flutter, AFib, can cause rapid ventricular rate and also cause blood clots to form, which can cause a heart attack, a pulmonary embolus, or a stroke. So first question, let's answer the 5 again. So let's start with, what does it look like? That's one type of AFib. Should be a second picture. No, you only have one picture. So only one strip. Okay, that's AFib. Okay. Like I said, in real life, the AFib can look different in other strips. Okay, but it's still AFib though. You see P waves here? No, these are not P waves. Okay? They don't look like P waves. We call them F waves or fibrillatory waves. They're F waves, they're not P waves. Causes, you have a whole chart. Chart 22-2. Age, number 1, hypertension, diabetes, obesity, valve disease, heart failure. So anything to do with increased pressure in the atria. So if there are any problems causing pressure increase, let's say heart failure, for instance, that increases pressure in all 4 chambers, yeah? But particularly increased pressure in the atria. Whenever you have any condition that causes increased pressure in the atria, it can cause AFib. AFib can be one time, meaning paroxysmal. It happens one time, never happens again. That's possible. It can also be persistent AFib, or it could be also long-standing, or it could also be permanent AFib. Okay, so there's different types. So that means how long your treatment goes depends on what type of AFib do you have. Okay. So we have what it looks like. We look at the causes already. So here are your types of AFib. Okay, so paroxysmal, persistent, long-standing, permanent. It's important to know non-valvular because the treatment will differ, especially with the choice of anticoagulants. Okay, with valvular AFib, the only choice is warfarin. Have you heard of warfarin? Coumadin. Okay, so warfarin is the only choice for valvular AFib. If it's non-valvular AFib, we have a variety of choices. Okay. Less harmful choices. But for valvular AFib, only warfarin is the option for anticoagulation. What does it mean? Meaning valvular, meaning caused by a valve problem. What were the valve problems we talked about last week? or 2 weeks ago, sorry. Yeah, so all those valve problems, okay, regurgitation or stenosis, okay, all of them cause AFib. Okay, I mean not all of them, but most of them will cause AFib. So if your AFib is non-valvular in nature, meaning you don't have a valve problem, you have AFib, you can use a different list of anticoagulants. If it's valvular, what's the only option? Warfarin alone. So signs and symptoms. Of course, there will be two sets of signs and symptoms here because there are two effects. One is low cardiac output, just like any dysrhythmia. What's the second set? Thrombosis, okay? Because this causes clots. Okay, because what happens when the rhythm is like this? So are the atria really contracting here? Because there's no P wave. So remember, what does P wave mean? The SA node fire the electrical impulse and the atria contracted. So we don't have P wave. So what two things are not seen here, are not happening? The SA node is not the one causing the impulses and the atria are not contracting. So if the atria are not contracting, is blood moving out of the atria? So what will blood do when they're in one place more than a few seconds? They will form blood clots. Okay. So your treatment will involve two sets of drugs. You have antidysrhythmics and also anticoagulants. We'll discuss the management shortly. Okay, let's go to management. All right. So of course, we look at the risk factors. We'll see what is the patient's risk factor. Because pregnancy is listed as one of the causes, yeah? So so this can be a pregnancy complication. If it's usually caused by pregnancy, usually resolves after childbirth. Patient gives birth, no more AFib. Okay, that's usually the case. Let's look at the drug treatment now. Let's start with antithrombics. Now, don't confuse antithrombics with anticoagulants. All right, they are actually not the same. So we have anticoagulants, which are your apixaban, you have your direct thrombin, indirect thrombin inhibitors. You also have your warfarin, which is your vitamin K antagonist, and then you have antiplatelets. Antiplatelets are antiplatelets are aspirin and clopidogrel. You heard of Plavix? Okay, so Plavix is clopidogrel. Aspirin and clopidogrel are antiplatelets. They are not anticoagulants. Are we clear? Okay, so antiplatelets are literally just antiplatelet, meaning they prevent platelets from clumping together. Anticoagulants, however, prevent a clot formation. Okay? So anticoagulants affect the clotting factors. Antiplatelets affect only platelets. Not the same. Which treatment is used? We do not make the decision. Are we clear? Doctor makes the decision whether they're put on antiplatelets only or dual. Patients on antiplatelets plus anticoagulants at the same time. Just remember though, the more of these drugs the patient is on, the higher the risk for bleeding. And that's where you come in. So you monitor the patient for signs and symptoms of bleeding, which you all discussed extensively during week 7 on your group presentations. So again, I won't test this part, the treatment guidelines, because are we the ones prescribing? No, the doctor needs this information, not us. All right, here's where we come in. Your responsibilities will be on the medications now, because you're the ones administering the anticoagulants, the antiplatelets. So this is where you come in. What do you monitor? If it's thrombin inhibitors like heparin, there's, what do you monitor? PTT, correct? Okay. What do you monitor for warfarin? PT-INR, okay. And then the doctor, of course, sets the goal, the target. If it's to prevent PE and a stroke, it's higher, it's 2 and 3. For DVTs, it's probably 1.5 to 2, especially if it's the first time DVT. But for patients with AFib, high risk for stroke, heart attacks, and PE, it's 2 and 3. It's quite higher. These patients are really at risk for bleeding. We'll discuss more in detail in chapter 26 when we go to pulmonary embolism next semester. Okay, so for now, this is all we need. You do need to know the names of the factor 10A inhibitors. So some of them were mentioned in week 7. 10A inhibitors are those that are apixaban, rivaroxaban, edoxaban, okay? Dabigatran, those are your direct 10A or factor 10A inhibitors. So one set are antithrombics. The second set of medications are medication that control the heart rate, because again, we don't want a rapid ventricular rate, because what happens is, remember when I said what I said about the AV node? What's the job of the AV node? Give me 2. What does the AV node do for you? It's a secondary to back up. What's the other job? To delay, very good, to delay the transmission from the SA node to the Purkinje fibers, yeah? Okay, the third job of the AV node is like a gatekeeper. Because are these really P waves? No, these are not P waves. Now, the job of the AV node is to recognize this as, this is not a P wave. So what will the AV node, what should the AV node do? Since this is not a P wave, what will it do? What should it do? Should it transmit this or no? No, it should not transmit it. So if the AV node is doing its job, we will not have a rapid ventricular response. However, if your AV node falls for this, meaning the AV node thinks, oh, then recognize this as not coming from the SA node, meaning the AV node mistook these F waves as P waves, we have a problem. Because look at each one. If there is a ventricular rate, a ventricular response here, there's a QRS after each one of these. Imagine this patient's heart rate. This will reach easily 200, 300, right? Okay, so that's the other job of the AV node, is to not fall for this thing, right? But if the patient's AV node did not, do its job very well, so now we have to do treatment. We have to choose one or more medications to lower this patient's heart rate. Number 1 choice is a beta blocker or a calcium channel blocker. Between the two though, because what happens to this patient's blood pressure? The heart rate's so fast. The blood pressure drops, yeah? Between a beta blocker and a calcium channel blocker though, calcium channel blocker has a lesser effect on blood pressure. A beta blocker will drop the blood pressure significantly. So if the blood pressure's on the soft side, it's too low, meaning you can't give the beta blocker, but you need the heart rate low, then the other option is calcium channel blocker, meaning they have the same effects, but the better choice would be or a safer choice would be the calcium channel blocker if the patient's blood pressure is too low, right? As a result of that really high rhythm. And then we also have, the doctor can choose to convert the rhythm if appropriate. Again, we don't decide, okay? Now, the problem with these medications is they're quite dangerous, okay? They can cause severe dysrhythmias. So we call these drugs chemical cardioverters, meaning we convert the rhythm using chemicals, using medications. They are lecanemide, dofetilide, propafenone, amiodarone, or IV albuterol. Again, these are dangerous medications, okay? They're okay, amiodarone is okay PO, but when you have to give these things IV, doctor has to give them, all right? These are dangerous. So they can convert the rhythm, but they also have very dangerous side effects. They can cause more serious dysrhythmias as a result, especially low heart rate. Okay, so the doctor will, of course, decide whether they want to do electrical cardioversion or the patient will have chemical cardioversion. Again, we don't choose, okay, the doctor makes that decision. If the patient has new onset, so let's say the patient is in labor, correct? Pregnant woman in labor goes into AFib, so it's new onset, correct? Less than 48 hours ago. So the doctor may choose electrical cardioversion. Discuss cardioversion, like I said, later in the chapter. So here's the electrical cardioversion. Again, this is using a have you seen a defibrillator? You know what a defibrillator looks like? Okay, let me show you a defibrillator. Not the AED, no. Can you see this picture? Everybody knows what a defibrillator looks like now. Okay. Again, not an AED, okay? So we need a defibrillator. Now, the defibrillator can function as a cardioverter using only one button. There's a synchronized button here, which if turned on, turns the machine into a cardioverter. Okay, but we're using the same machine, okay? Same equipment, functions as a defibrillator and a cardioverter at the same time, right? So if you're using this as a cardioverter, what button do you need to turn on? Synchronized button. Okay, it'll be, of course, it won't say synchronized, it will just say sync, okay, SYNC. So if you turn on the sync button, what does the machine become? A cardioverter. Okay, so it's no longer a defibrillator, it's now a cardioverter. Okay. So what's the difference between the two? A defibrillator, you've done your BLS, yeah, with Jim. Okay, so how did the AED function? When did it fire the electric shock? When you did what? What did you do? Yeah, you yelled clear, but then what did you press? You press the shock button, yeah? Okay, so that's when a defibrillator delivers the electric shock, when you press a button, okay? So either the button on the AED machine or the button on the paddles if you're using a LifePak defibrillator, right? So that's how a defibrillator works. So it works whenever someone presses the button, okay? If used as a cardioverter, yes, you still press the shock button, but if the synchronized button is on, it does not deliver the shock right away. It delays it because it has to sync with the patient's rhythm first, right? That's why it's called synchronized cardioversion. So it analyzes the patient's rhythm and then delivers the electric shock at the peak of an R wave. Okay, so the difference between a defibrillator and a cardioversion is what again? What's one difference? What button do you turn on? A sync button. You want to use it as a cardioverter. And once the sync button is on, when you press the shock button, when is the shock delivered? Only at the peak of an R wave. Meaning, if you do a defibrillation, when is the shock delivered? Whenever you press the button. So is it timed at all at the certain point of the cardiac cycle? No, it's randomly delivered whenever you press the button. However, if used as a cardioversion and the synchronizer button is on, when is the shock delivered? At the peak of an R wave. So it's timed specifically at the peak of an R wave of the cardiac cycle, right? It may take 1 or 2 shocks before the patient converts to sinus. But again, that's your only job. When we do cardioversion, of course, cardioversion is scheduled, yeah? Meaning with defibrillation, did you schedule defibrillation? Like, can you do, okay, let's defibrillate you at 9 o'clock, okay? So you have a heart attack, you go into cardiac arrest at 9 o'clock, all right? And then we'll defibrillate you. Can you do that? No, you can't schedule defibrillation. Can you schedule cardioversion? Yes, absolutely. Now, imagine, in defibrillation, is the patient aware of the defibrillation? No, because you had just had cardiac arrest, right? You were in. What are the 2 shock rhythms again that are shockable? Jim said, what are those 2? VFib and pulseless VTAP. Okay, so VFib and pulseless VTAP. Cardioversion is indicated 1 for AFib. Okay, so there are many other indications, but 1 is AFib. Since we can schedule this, and is this patient awake? The one when we do cardioversion? Is this patient in cardiac arrest? No, they're fully awake, right? So let's say you're awake, Miss Claude, and we're doing cardioversion on you. Is that okay? We're gonna shock you, right? Okay, so I'll just give you so here's a piece of stick. Okay, put it between your teeth, and I'm gonna shock you now. Okay, are you okay? Are you ready? Well, we have to do this. Okay, so just bite on that stick. Okay. Are you gonna be comfortable? No. So one requirement is what? We can sedate you. Okay, so we'll give you a small sedative, sedate you for a few minutes, and then perform cardioversion. Are we clear? All right, so those are the differences. Okay. Any questions on cardioversion? Okay, so we'll end here. I have no more time. So quiz next week would be from the beginning of dysrhythmias up to AFib. Okay, we'll finish up next week.